Udavartani Yonivyapad or Dysmenorrhea. Acharya Charak says that the uterus is seized with pain, pushes the raja or menstrual blood upwards and then discharges with great difficulty and pain. The lady feels comfort after discharging the menstrual blood. According to Shushrup, he has described it to be characterized by painful Prati menstruation associated with other Vatic disorder. On the basis of the symptoms of great difficulty at the beginning of menstruation and immediate relief of pain following discharge of the menstrual blood given by Charak, it is identical symptom of primary or spasmodic dysmenorrhea. So, what is dysmenorrhea? Dysmenorrhea refers to the chronic cyclic pain or discomfort in the pelvic region during a menstrual cycle, during the menstrual period. It is also described as painful menstruation of the sufficient magnitude so as to incapacitate day-to-day activity. Types of dysmenorrhea. There are two types of dysmenorrhea. First one is primary, which is also called as idiopathic, spasmodic or true dysmenorrhea. Second one is secondary dysmenorrhea. The primary dysmenorrhea is a pain which is of totally uterine origin and directly linked to menstruation but no visible pelvic pathology has seen. The causes of pain during menstruation are: first one is psychosomatic factor. During adolescent period of the life, the tension and anxiety during adolescence lowers the pain threshold. In ovulatory cycle, there is a secretion of prostaglandins which are synthesized from the secretory endometrium. The PGF2 alpha is a strong vasoconstrictor which causes ischemia of the myometrium, either due to increased production of prostaglandins or increased sensitivity of the myometrium to the normal production of prostaglandins. There is increased myometrial contraction with or without dysrhythmia. Second one is increased vasopressin secretion. The increased vasopressin released secretion during menstruation in women with primary dysmenorrhea. Vasopressin increases prostaglandin synthesis. It causes uterine hyperactivity and dysrhythmic contraction, which leads to ischemia and hypoxia, which leads into the pain. Endothelins. In endometrium, it also induce PGF2 alpha, leukotrienes, and PAFs are vasoconstrictions and constrictors and stimulate the myometrial contraction. Last one is overactivity of the sympathetic nerves. The sympathetic nerve leads to the overactivity of the sympathetic nerves leads to hypertonicity of the circular fibers of the isthmus and internal nerves. The relief of pain following dilatation of the cervix or following vaginal delivery may be due to damage of the adrenergic nerves which aggravates the pain. What are the clinical features of the primary dysmenorrhea? In the primary dysmenorrhea, the pain begins a few hours before or just with the onset of menstruation. The severity of pain usually lasts for a few hours, may extend to 24 hours, but seldom persists beyond 48 hours. The pain is spasmodic and confined to the lower abdomen, may radiate to the back and medial aspect of thighs. Systematic Systemic discomforts like nausea, vomiting, fatigue, diarrhea, headache, and tachycardia may be associated. It may be accompanied by vasomotor changes like pallor, cold sweat, and occasional fainting. Rarely, syncope and collapse in severe cases may be associated. On examination or investigation, there are no visible pathology is seen. Secondary dysmenorrhea. A pain which is associated with uterine or pelvic pathology like cervical stenosis, chronic pelvic infection, pelvic endometriosis, pelvic adhesions, adenomyosis, uterine fibroid, endometrial polyp, IUCD in utero, and obstruction due to Mullerian malformations lead to secondary dysmenorrhea. What are the clinical features in this? The pain is dull, situated in the back and in front without any radiation. It usually appears 3 to 5 days prior to the period and relieves with the start of bleeding. The onset and duration of pain depends on the pathology producing the pain. There is no systemic discomfort like primary dysmenorrhea. There are symptoms of associated pelvic pathology. On examination and investigation, the abdominal and pelvic examination usually reveals the offending lesions for detection of any pelvic abnormalities. Ultrasound is very useful and it is not invasive. At times, the lesion is revealed by laparoscopy, hysteroscopy, or laparotomy. What are the treatment? Treatment aims to the cause rather than the symptoms. The type of treatment depends on the severity, age, and parity of the patient. Other type of dysmenorrhea is pelvic congestion syndrome and membranous dysmenorrhea. In pelvic congestion syndrome, there is disturbance in the autonomic nervous system, which may lead to gross vascular congestion and pelvic varicosities. The patient has a congestive type of dysmenorrhea without any demonstrable pelvic pathology. The patient complains of weight disorders with backache and pelvic pain with long-standing positions, at times with dyspareunia. There may be menorrhagia or epimenorrhagia. The uterus may feel bulky and boggy. Diagnosis is made by physical examination, radiologic study, pelvic venography, Doppler scan, duplex ultrasound scan, CT, MRI, or angiography. Laparoscopic diagnosis is difficult as with intraperitoneal pressure and Trendelenburg position, these vessels may be compressed but will reappear as the pressure is reduced. In membranous dysmenorrhea, there is a very rare condition with a familial incidence in which the endometrium is shed as a cast at the time of menstruation. The passage of cast is accompanied by painful uterine cramps. It has been proposed that this phenomena may be due to deficiency of tryptic ferment that is normally secreted in the endometrium. What are the management of the dysmenorrhea, especially primary dysmenorrhea? Improvement of the journal health and simple psychotherapy in terms of explanation and assurance, especially during adolescent period. Usual activities like sports are to be continued. During menses, bowels should be kept empty. Mild analgesic and spasmodic antispasmodic may be prescribed. Habit-forming drugs such as pethidine or morphine must not be prescribed. The drugs used are first one is prostaglandin synthetase inhibitor like mefenamic acid. The dose is 250 to 500 milligram 8 hourly or flufenamic acid 100 to 200 milligram 8 hourly for 3 to 6 cycles. Propionic acid derivatives ibuprofen 400 milligram 8 hourly or naproxen 250 milligram 6 hourly. Oral contraceptives combined estrogen and progestogen from the day 5 of the cycle for 20 days that should be continued for the 6 cycles. Surgery. If the above protocol fail, laparoscopy is indicated to find out any pelvic pathology to account for pain. The important one being endometriosis. The surgery performed are transcutaneous electrical nerve stimulation, laparoscopic uterine nerve ablation, laparoscopic presacral neurectomy to cut down the sensory pathways from the uterus, slow dilatation of the cervix to relieve pain by damaging the sensory nerve endings.